like to invite Dr. Bhaskar for his talk on cataract surgery in eyes with PK and RK.
A very good morning to one and all. I'll be speaking on cataract surgery in PK and RK and the challenges. No financial disclosures. So basically, when you're looking at RK eyes, Sagar did cover it. What's the problem? The problem is basically the significant central flattening that is there, the irregularity that can be there. It could be associated rarely even with ectasias. You have an unstable wound which can gape as you make your incisions. You are dealing with a high myopic eye, so your chamber might actually be deep. Your scleral rigidity will be less, and all this with the issue with your IOL calculation, you might end up with a post-operative IOL surprise. As far as IOL calculation is concerned, the reason for the error is the inaccurate keratometric value. You have an an erroneous ELP if you're going to be using, say, a formula like SRKT, which uses the corneal curvature as a surrogate for ELP as such. It's already a multifocal cornea, so it becomes very difficult, especially if it's not a very well-centered RK, for calculating the IOL power. And post-operatively, there is a bit of edema of the incisions, so it takes a little bit longer for your refraction to stabilize, unlike a regular cataract surgery. So when you're planning for a cataract surgery in an RK eye, the first and most important step is to look at the topography. I mean, it's okay to put the values in the ACRS calculator, but the most important thing is you need to know how accurate your values are going to be. If your topography is regular in the center, you know you're going to be close to the intended target. But if you have a decentered flattening, then you know whatever you're doing, it's like a hit or a miss kind of a calculation, and you need to be aware of that and tell the patient subsequently. And if it is like what Sagar showed in terms of an irregular decentration, then you might even consider regularizing it with some kind of a laser ablation and then planning for a cataract surgery. Obviously, a detailed retinal evaluation is important. With respect to the cornea, before you plan the surgery, you need to know the number of cuts, because you need to decide whether you are going to be making a corneal incision or you're going to be making a scleral incision. So if you have less than 8, you just have, say, a 4 incision RK, then you can even make a corneal incision. But if you have 8 or a 16 mm cuts, then you would probably want to make a scleral incision as such. If you're making an incision whether your side port or your corneal incision has to be such that the width is within the cut margin, so that it doesn't cause a rip-off of the RK incisions. During the surgery, your bottle height has to be low, because you're dealing with a highly myopic eye. Incision length can be a little bit smaller, because if the chamber deepens, then you will have a lot of distortion. Already the corneal scar and the central haze will make your visibility a bit of a challenge. So distortion on the cornea will make it more difficult. And initially you might, if you end up, say, on day 1, day 2, if you're doing a refraction and you end up with a slight hyperopia, you will actually end up plano post-op. If on day 1 you are actually plano, you will end up about a 0.5, 0.75 myopic at about a month's time. So the stabilization will probably take about a month. So, so this is just 2 eyes of the same patient. One eye has had a cataract surgery done elsewhere and has a corneal decompensation, and we need to now decide whether we want to do an EK or a PK. And the other eye has had cataract and we've just operated the eye. What's important is to look at the topography. So you're evaluating the patient, you look at the topography. Here, luckily, it's fairly centered. Endothelial counts were good, so at least that part of the cornea is taken care of. It was easier for us to get a value as far as what is the ACRS value was similar to your IOL master value also. And we said, okay, we'll go ahead. We actually did a modified or an advanced monovision lens, and she's ended up at 6.6 with a 0.5 myopia at 1 month post-op, and she's N10 unaided. So it kind of, we reached what we aimed for, and this was essential because it was still a reasonably regular topography. So once you have a regular topography, it's a lot easier. Now this eye has only 4 cuts, but there is an ectasia. So now this makes calculation a lot difficult, because the cornea is completely bizarre, and the patient is using contact lenses. So the decision was whether we want to do a PK with a cataract surgery, but the patient doesn't want a doesn't want a PK or an LK. Patient is happy to continue with contact lenses. So at least to that extent, I'm okay, even if my calculation goes haywire. She's going to be using contact lenses, but you still want to be as close to your intended spectacle calculation. And luckily, we aimed for about a 9, and she ended up with around a +1 with a -2 cylinder. So it was more here when we actually calculated. every formula was giving us a different value ranging from 6 to 15. So the only good part was I had done some calculation about 2 years back, and the other eye, when I had operated, the other eye was bang on target. So I kind of said, okay, I'll take the value which is closest to the other eye, because both eyes to begin with had a similar refraction. But having said that, this ectasia is progressing, so I would still have been hitting in the dark, not knowing what I'm targeting. So this is another interesting case where patient had an RD surgery, post-RK patient, had oil and needed cataract surgery. And topography was reasonably regular, so fine, surgery went on fine, absolutely fine. On post-op day 1, sorry, 1 second, where is it not coming? What happened? Yeah. So on post-op, sorry, day 4 or 5, the patient is saying vision is very poor, and I just got, I could see a distortion in the cornea, and I just asked them to get the topography. It is showing a significant astigmatism pattern now, because the wound was, sclerotomy wound was leaking, so they've really tightened the sclerotomy so much that's induced the significant astigmatism, almost about 10 diopter of astigmatism, just by trying to tighten the wound to leak. Since it was a leaky wound, I didn't want to remove the suture. Anyway, it was a vicral suture. I said, okay, let's wait for a month, it will kind of stabilize, and it kind of stabilized in a month's time. So if you're doing a combined surgery, you might need to tell your VR colleague that you might want to be a little bit gentle with the sclerotomy suturing as such. So this is a video, thanks to Mona for the video. Why is it not playing? So this is a cataract surgery in an RK. So you can see the multiple number of cuts. So it's a lot, but you need to really plan your incision width, so that you don't extend into any of your RK marks. This patient also had a trab, so the space that you're working with also reduces as such. Once your incisions are made, the difficult part is primarily the calculation and the incision. So once these two are done, unlike Sagar's case, which had a large bag, which had a bit of a zonurodialysis because it was highly myopic, if it's not as bad, you might be able to get away with a regular cataract as such. Obviously your axis has to be reasonably large enough, ideal size, and then the surgery gets over. If there is a gape of the wound, you might want to take a single suture, or you would want to take a lasso suture all around to kind of make sure that your incisions don't open up as such. So it's important to realize and be ready with this when you are starting your surgery. Otherwise, in a normal phaco, you might not need a suture, so your staff might not keep it, but in these cases, you can make sure that you keep it ready. Coming to post-PK cataract, obviously you need to decide on the IOL calculation. So again, if it's a fairly regular topography that you have, great, you might even consider doing a toric lens. Only caveat is, if this graft fails, then you will have to do only an EK. If you're going to be doing a PK, then you have to change the lens based on your standard K. So if you're putting a toric lens, you have to then be more proactive if the patient develops a graft rejection and you're planning for a repeat transplant. You would ideally want to remove all sutures, wait for about 6 months for the corneal topography to stabilize, and then do the surgery. If you have a very large graft and you have taken, say, 11 or 12 mm sutures are under the conjunctiva, they are not loose, you might probably go ahead with a cataract surgery if it's a total cataract without being too worried, because those sutures which are so far away will not cause issues with your IOL calculation, because the effect of the sutures so far from the center will not cause a change in your refraction significantly. You would take all measures to protect the graft, which would be a dispersive viscoelastic, obviously an in the bag phaco emulsification, and you would want to avoid a PCR at all costs. You don't want to increase the time that you're spending in the anterior chamber. If you're putting a toric lens and there is a difference in the axis of astigmatism and your topographic astigmatism, like Sagar said, you will probably go back to what vision the patient had and how close the topographic axis and the refractive axis matches. If there is no match, then you will not put a toric IOL. If there is a match, you can go ahead with the toric IOL, even if you don't have a regular bow tie. If the patient was using contact lenses for best vision prior to cataract surgery because of the graft being irregular, obviously he will continue to use contact lenses post-operatively unless you address the irregular astigmatism either using a topo-guided treatment or resuturing the graft and then planning cataract surgery subsequently. or combining a PK or an anterior LK to reduce the astigmatism with the cataract surgery. So this was a patient who had a fungal keratitis, a patient with PACG who presented with perforation. We did a therapeutic graft. The chamber was very shallow, so we actually had to do a pars plana limited anterior vitrectomy to kind of make sure that the chamber is formed in the early postoperative period. And this is almost now 8 years. After this, he had a cataract surgery after about a year, and this is almost now 8 years post the cataract surgery. His only eye, he's maintaining 618 vision. So this was a patient who had a PK. Patient was a patient with atopic keratoconjunctivitis. Somebody had planned an LK, but it ended up with a PK. So PK part was fine, sutures were out, but she has a shield cataract. So we went ahead and did a toric IOL. So it's not a very regular bow tie, but it was kind of matching the refraction that we had, and we went ahead with a toric lens, and she ended up with a 0.75 SIL, improving to 6.6. This was a patient with a keratoglobus, where we've done a large diameter limbal sparing LK, and then subsequently went ahead with a cataract surgery. This was again a patient who had very severe myopia, so the axial length was around 34. So this is a patient who had macular dystrophy in both eyes. We did a PK in one eye, we did a DALK in the other eye. So this was an eye where we had done the PK first, had a recurrence of the dystrophy in the graft, but it was not so bad that I needed to redo the procedure. He developed cataract. So the question was whether I would want to just repeat the PK along with the cataract surgery, which would have made my life a lot more simpler in terms of visibility, but the patient did not want to get a PK done. So then you use all measures to improve the visibility, trypan blue, light pipe, make sure that you coat the endothelium because you don't want the endothelial cells to be damaged. So using a light pipe or a chandelier will kind of give you the ability to see the capsule more clearly. The most important part is probably going to be, because the cataract itself is not going to be the challenge is your excess. Once your excess is done, then to a large extent it becomes a lot easier as far as this eye is concerned. So here we did a stop and chop where we got a groove, cracked it, and then once that is done, then it's like any routine phaco. So the staff has to be smart enough to keep holding it. You might want to switch off the microscope light completely so you're able to see it. Or the option would be to put a chandelier at the back so you get some kind of a retro glow, but that will be a pars plana entry, or you'll have to keep a chandelier in the anterior chamber. But even if you keep a chandelier in the anterior chamber, it just gives you a light in one direction. It doesn't give you the same illumination that you get when you place it at the limbus. So even coating the surface with a viscoelastic will actually improve the visibility because of the magnification becoming better. And these other safety parameters in terms of a dispersive viscoelastic, reduced phaco time, in the bag phaco. Maybe flax would probably be an option because it takes care of multiple things in this situation. So you get your excess, you get your nucleotomy done. It becomes a lot easier. Obviously the cost is going to be an issue in that as such. So to conclude, you need a very good proper preoperative evaluation. The ACR is calculated both for LASIK and RK, seems to work reasonably well. When you're operating any of these eyes with endothelial compromise, you will need to protect the endothelium with all measures to get a good predictable outcome.